Good afternoon, everyone. My name is Maria with TMC for Seniors, and we are going to be having a lot of heart health talks this week. And we're going to start off with our clinical trials shaping the future of cardiac care. I have Ariana Ehsan here with me. She is with TMC Health. She is a clinical research investigator. She's got lots of different types of trials that she's going to be talking about today. How are you, Dr. Ehsan?
I'm good, thank you. How are you?
Good. We have an online audience that's watching with us, along with a small in-person audience. If you're watching from home and if you have a question for Dr. Ehsan, please leave those in the chat for me and I will ask her when she finishes. I'm going to go ahead and put up your PowerPoint for you so that you can get started when you're ready.
Perfect. We got one more person coming in and then we'll go ahead and get started.
All right.
All right. So my name is Dr. Ehsan. I am here with TMC Health. I work for the Clinical Research Department. And this is one of my favorite months of the whole year. I have given this talk last year. I'm giving it to you today, and I plan to give it every single year because I absolutely love this time of the year and this time that we get to spend together, and we get to talk about all the clinical trials that we have here as options for our patients. So the way our presentation is set up a bit is I'm going to give you a lowdown of the team, the clinical research team here at TMC. I'll show you the list of our active cardiovascular clinical trials. I've added a glossary because there's some words that we use in the clinical research space that we don't regularly use. So if you've got that packet there, you can see it on there and you can reference back to it, but we'll go through them quickly here as well. And then I'll show you how we're going to kind of organize each clinical trial, how we'll look at it, and then we'll get to know your heart in general, and we'll look at all the clinical trials together. So here is our main team, our leadership team. We have Dr. Tom Wagner, who's the medical director of cardiac research, and he's with Pima Heart and Vascular, and he does all his procedures here at TMC Health. We have Natalia Elias-Kayas, she's our director of clinical research. And then you have myself, Dr. Ehsan. I am a clinical research investigator, and I'm a program director for our fellowship program here. Our office is just across the street. It's on the south side of Grant, next to the TMC Outpatient Therapy Center, so we're really not that far. And then I've got my team listed here with our research fellows, our biostatistician, our supervisor, our coordinators, and our research assistant. So some programs have 20 people and 30 people. We are small but mighty, and I love it because a lot of our team gets to see every single patient that comes through the door. So there's a lot of consistency there. Here's that list of active studies. So you'll notice that I've got the pathology written, meaning what is the disease that we're talking about, what the clinical trial and study name is, and then the actual device. And if you notice when you walked in, I've got a bunch of things sitting right here, and a lot of these are the devices that we'll talk about throughout these slides. And at the end, please feel free to come up. You can touch any of them. Don't take any home. But you can play with them and you can kind of get a feel for what it is that we're talking about. Here's that glossary. So if you guys want to flip to that, so you can kind of follow along. A participant or a subject, which you will hear me say a few times, is a person who volunteers to take part in a clinical study or trial. So that could be any of you if you volunteer to move forward and you meet the criteria that is required for one of these interventions. A prospective trial or a prospective study follows a group of people over time and observe how they develop. So it's now and into the future. And a retrospective trial analyzes data from patients who have already been diagnosed with something or have already been treated for something. So we look backwards and we look kind of at the medical chart and say, let's see how that developed. Blinded means that participants, folks who volunteer for these studies, do not know which treatment they are receiving. Unblinded means participants are aware of what treatment they are receiving. A control group are participants who do not receive the treatment being studied in the trial, but they'll receive standard of care, or in some cases, placebo. More often than not in the trials that we have, if it is a study that has a control group, it means you get the standard of care treatment. Randomized, which you're going to hear a lot today, compares the effects of different treatment on groups of people and includes a control group. And this is the most reliable way for us to compare a treatment, because the only way, or one of the most reliable ways to know that something is really working, is to compare it to whatever is the standard of care, right? Non-randomized or single arm means all participants receive the treatment being studied and there is no control group. Generally, these studies are smaller. There's not thousands and thousands of patients in this trial. It is generally a trial that has maybe 200 or 400 or 600 patients. Multi-center means a study that involves multiple hospitals or medical institutions that enroll and follow participants. So we are one of the centers that offers these trials that we'll talk about. And then there are other hospitals across the US that also offer it. And GDMT is guideline-directed medical therapy. So oftentimes there's a lot of guideline-directed medical treatment with medications for whatever disease it is we're talking about. So this is what each slide will look like. We will have the clinical trial and study name at the top. We will have a list of investigators, which are the physicians and the nurse practitioners who are directly involved with this clinical trial or the study. And then we'll have 4 sections. We'll have the study design, meaning how is the clinical trial or study set up in terms of retrospective or prospective, the different treatment groups or cohorts, if it's randomized or not, if there's a single hospital that's involved, just TMC, or if it's a multi-center, and a brief description of what the goal is. And then we have the patient population. Who would we possibly suggest this as an option to, and who could potentially benefit from having this intervention or being in this trial? Primary endpoints is our 3rd section. What is the clinical trial or study additionally trying to prove or review or assess? And then we have study enrollment goals. This will be the number of hospitals or sites that are participating in this clinical trial, and it will also be the number of patients who will be enrolled. And then at the bottom, we'll have a photo of the intervention or the device or the clinical trial. So we'll start with just getting to know your heart. The way I tell patients in office is I say, if you look at me just like this, and you slice me down in the middle and you look straight into my chest here, that's what it's gonna look like. You've got the right side of the heart and you've got the left side of the heart. And I like this picture because it's split up by color. So on the right side is all blue and on the left side is all red. So that's how that heart looks here. And now this heart is missing something. So I've added it myself because I'm an artist. There it is, that little black line that I put in there. And that is a left atrial appendage. Folks who have AFib generally know about their left atrial appendage or some sort of an arrhythmia. If they don't have AFib or AFlutter or an arrhythmia like that, they often don't hear about their left atrial appendage. But we are going to talk about it here in just a second, so I had to draw it in there for you guys. So let's start with AFib. We're going to start going through that list of clinical trials. We will start with our AFib section, and I'd like to show you what does that actually mean. So if you look at the blue hearts here, that first heart shows you a typical heart rhythm. That's the normal way the heart is beating. And we can feel our heartbeat and we can put our fingers here and feel it, and our physician feels it, and we check our blood pressure, it tells us. And so this is normal. And our heart really kind of creates its own electricity, right? It will pump itself. When someone is in AFib, it'll look like that second blue heart. And what I tell folks is it's kind of like this top area of your heart decides to dance to the beat of its own drum. It doesn't want to follow any rules. It wants to be on its own and do whatever it can, which doesn't work out too well when you're experiencing AFib, because for some folks that can mean that they feel very short of breath. They can feel their heart racing. It's hard for them to walk from here to that door. So it can feel really stressful on the body. Other folks who are in AFib may not feel it at all. It just depends on how you present. We've got that other picture there. It's just another one showing that AFib in that top left room there. And that one actually has that pocket there, that left atrial appendage. And what you'll notice in this picture is it says site of clot formation in left atrial appendage. What we worry about in folks who have AFib is we worry about the chances of a clot developing in that pocket there. That pocket is kind of like the appendix in our gut. It doesn't really help us out in any way, and if you have AFib, it can be quite dangerous. So when your heart is in AFib and that heartbeat is erratic, blood is kind of sloshing around in the top as opposed to pumping the way that it needs to. And when that blood gets into that pocket, it will kind of slosh around and it'll kind of vibrate in there. And over time, and it's not that long, it can take only up to 6 hours that blood can clot. Now, when that blood clot pops out, when the heart goes back into regular rhythm, it'll make its way down into the bottom left room, and then it'll make its way up the aorta. And the aorta is the freeway to the whole body. It gets all the oxygenated blood, brain, gut, toes, and everywhere in between. So if that clot pops out and it gets into the bottom left room and it goes into the aorta, well, those branches that you see coming off the aorta, those first few go straight to the brain. So that's why we're so worried about stroke in folks who have AFib. And that's why if you have AFib or if you know someone who has AFib, they are most likely, or you're most likely to be on some sort of a blood thinner because we don't want that clot to develop. But sometimes folks can't tolerate the blood thinner. And that's what gets us into a couple different trials that we have. So why don't we go ahead and get started? Our first trial is Catalyst, and this is the device that is really being tested. Now, some of you may think that this is familiar, and that's because this is actually available on the market for patients to have the procedure now. But we'll talk about why it's in a trial here. So we've got our investigators listed there, and I'm not going to go through the list every single time since you guys have the papers there. We'll make it easy on you. So the study design is prospective, meaning we're going to treat patients and we're going to follow them into the future. It is randomized 1-to-1, meaning one patient will receive this and another patient won't receive this. It is a multi-center study, meaning we're not the only hospital that offers this as an option in the United States. And this is to evaluate the safety and the effectiveness of the Amplatz or Amulet device compared to non-vitamin K oral anticoagulant NOAC therapy. Mouthful. Have you guys heard of medications like Eliquis and Xarelto? That's what that means. Okay, so we're comparing this device to those blood thinners that we have folks on for AFib. The patient population here is a little interesting. So non-valvular AFib, meaning it's not your valve that's causing the issue, it's just straight up AFib. And subjects who with increased risk for ischemic stroke or systemic embolism that are eligible for long-term NOAC therapy. Meaning, right now what the insurance company says is, hey, you know what? When I give you that Eliquis and I give you that Xarelto and you take it, you're tolerating it pretty well. You are not having GI bleeds, you're not having blood in your stool, you're not having a bunch of bleeds from the nose and you need to get cauterized, you're not falling left and right. So I know you don't like to take the blood thinner, and I know that you got a lot of bruises and you feel like your skin is thin, but you're tolerating it just fine. You keep taking that. This trial is made for patients like that who say, I understand insurance company that I can, but I would really like not to. And I have AFib and I still want to protect myself from having a stroke. I just don't want to have to take a blood thinner every single day. So this trial is meant for those patients. The primary endpoint of this trial, what we're trying to also see, to also assess, is stroke, whether it's ischemic or a systemic embolism, a cardiovascular mortality of 2 years, major, irrelevant, and non-major bleeding, ischemic stroke or systemic embolism through 3 years. There's 150 hospitals that are participating in this, and there will be 2,650 patients. And you've got that picture there of the heart, and I've got a circle around that left atrial appendage that we talked about, and then I've got this device, and it's a bit bigger there. Next, we have the CONFORM trial, and that device is right here. It does the same thing that this amulet device does, but it looks a bit different, right? This is that amulet device, and this is the CONFORM device. So,
Can you show it?
oh yeah, here we go. That's the CONFORM device there. So, I'll go ahead and put that picture up too to make it a bit more helpful. This is a prospective trial. It is randomized 1-to-1. It is a multi-center study to evaluate the safety and the efficacy of the conformal device, demonstrating non-inferiority to currently available left atrial appendage closure devices. So there are a couple devices that are currently available for patients who have AFib that cannot tolerate their blood thinners. You guys may have seen some commercials or know of someone who has a Watchman that Boston Scientific makes. So that's one of the options that's available. And then we talked about how this is also available to patients who can't tolerate a blood thinner. So what the CONFORM study is doing is they are taking their device and they're saying, let's compare it to what's already on the market. And I think I'll be just as good as blocking off that pocket and protecting you from a stroke as those other devices that are out there. This patient population are folks with AFib that have an increased risk for those ischemic strokes or systemic embolisms, and that are unable to tolerate those long-term NOACs. The primary endpoints are major procedure-related complications within 12 months and deemed procedure-related, as well as ischemic stroke and systemic embolism through 18 months. There will be 100 sites that are involved in this, and there will be 1,900 patients. Here we have the laminar LAAX trial. This is a prospective randomized 1-to-1 trial, multi-center study evaluating the safety and efficacy of the laminar system to currently available left atrial appendage closure devices. So this trial is set up the same way as the CONFORM study is. Now this one is a bit harder to see. I actually have it in a model here, and it's in a 3D printed model of a patient's heart, actually. So once you come up close, I'll be able to show it to you. So that picture might be a little bit more helpful right now. But the way that it looks, if you see in picture D there, it's kind of like a whisk, like you would use for eggs. And what this device does is it actually goes into that pocket. It grabs onto the tissue, and you can't really feel anything, and it will twist it back on itself. When you are in utero and your heart is growing, that pocket grows out of the top left room and it grows clockwise. So the way this device works is it goes in and it turns it counterclockwise. So it basically says, go back to the way that you came. And it puts a lock on it, which you can kind of see there at the bottom. And that lock looks a bit like a flower. So this is also for patients with AFib. And this is for folks who have the increased risk of ischemic stroke or systemic embolism that are unable to tolerate that long-term NOAC. The primary endpoints are composite rate of all-cause mortality, major bleeding, pericardial effusion requiring drainage, device embolization, and device or procedure-related events requiring intervention at 12 months. There will be 100 sites and 1,500 patients. Then we've got the SimpliFade trial, and this trial is a bit different than all the other ones. So this one is actually about the Watchman device. And this study is prospective. It is randomized 1-to-1-to-1. And it is a multi-center study to demonstrate the safety and effectiveness of different medication regimens after a patient has their Watchman procedure. So Watchman is used quite often. It is made by Boston Scientific. I've got 3 of them up here, so when we're done, I'll have you guys come on up and you can squeeze them and play with them just to really see what it looks like, and there are a couple different sizes. But the new Watchman device is actually drug-coated, and so this should help and does help with scar tissue growing over that pocket, so that pocket ceases to exist. And what we're looking at in this SimpliFade study is patients who are already scheduled to have their Watchman procedure. What we do is after they have their Watchman procedure, we look at 3 different options of how the medication regimen will be post-procedure, because scar tissue doesn't develop immediately, right? The same way when you fall and you scratch yourself, it takes some time for a scar to develop. Same way inside the body. So There are 3 different arms to this study, and I'll show it to you on the next slide, actually. So this is those, again, AFib patients who are unable to tolerate the NOAC. The composite rate of, or the primary endpoint is composite rate of all death, all strokes, systemic embolism, major bleeding at 6 months after randomization. There will be 125 sites, and there will be 1,857 patients. These are those 3 different groups that I was talking about here. So normally after a patient were to have a Watchman device, let's say that they were taking their Eliquis twice a day before they had their procedure. And what will happen is they'll come into TMC and they'll have their Watchman procedure. And after that, generally, they will go back on their Eliquis twice a day. And after 45 days, they'll have a procedure called a TEE, where a probe is put down the esophagus and pictures are taken of the heart. And the reason they do it that way is because the heart sits right on top of that food tube. So it's quite easy to see that pocket. And what we're looking for is, did that scar tissue grow over? If it grew over, fantastic, you come off the Eliquis, but you have to go on to DAPT. You'll see it there at the bottom. It is a medication called clopidogrel or Plavix, and patients are then put on aspirin. And they'll do that for another 4-ish months. And then after that, they'll come off the blood thinner. So that's normal. But what we notice is that generally when patients have significant nosebleeds or they have GI bleeds or they have significant falls, there's a bunch of different things that can make their care team make an adjustment to how that medication regimen will be after they have their Watchman. So what this study is looking at is it's taking all these medications that are already approved and that we already treat patients with, and we're actually just following the data and saying, when you have your Watchman, you'll go on aspirin after. And when you have your Watchman, you'll do a low dose Eliquis for 3 months, and then you'll go on aspirin after. And when you have your Watchman, you'll go on that regular Plavix and the aspirin like folks normally would. And we'll just compare, because this is the best way for us to get additional data to support what folks have already been doing in practice. So your procedure happens normally, your medication regimen is adjusted per the randomization, and then you have the research team follow you along with your clinical team. So that was all things AFib, but let's go ahead and get into heart and valvular anatomy. So our heart, like we talked about, you slice me down to it straight into my chest, right? And we talked about a right side and a left side and a top half and a bottom half. Well, we've got it here, and I've got your valves labeled for you. You've got on the right side, you've got the tricuspid valve and the pulmonic valve, and then on the left side, you've got the aortic valve and the mitral valve. And we'll talk about 3 of them today. We'll talk about the aortic valve, the mitral valve, and the tricuspid valve. And the way that I explain valves to patients that I find to be the easiest is I explain it to them like it's a door. So if we are talking about the left side of the heart, what happens is blood will fill in from the lungs and it will come into this top left room here. And in order to get from one room to another, just like you guys came in here, is through the door, right? So that door has to open to allow blood to rush forward into the next room. And then that door for the aorta has to open to allow that oxygenated blood to move to the whole body through that freeway, right? So our valves are just doors. That's all they are. And they open and shut based on how much volume is in the room and how much pressure is there in order to push those doors open. So when someone hears that they had an ultrasound of the heart and someone says, oh gosh, you kind of have a leaky valve. Gosh, you kind of have a tight valve. Think about it like a door. If you have a leaky door, it means that your door, once it opens and it's time for it to shut, it doesn't shut all the way. So the same way we would feel a draft from that door, that's the blood rushing back in the opposite direction than it's supposed to go. If someone says, hey, you have a tight valve or a stenotic valve, it means it's really, really hard to open the door. Imagine if our door expands a little bit in that frame. It's kind of hard for us to pull it, right? In our body, that tightness generally is calcium buildup around the door frame and the door hinges. So if we had a bunch of buildup there, it would be kind of hard to open that door, right? So our valves are just like doors. Either they're opening and shutting the way they need to, or They're opening and not shutting all the way, so we have a draft and that's leakiness, or there's some calcium buildup and when we try to open it, it's really hard to get it open. So we'll go ahead and start with the aortic valve. This trial is called Align-AR, and it is this valve here. It is the Jenna valve. It looks a bit like a crown, and that is actually their logo. So when you guys come on up here and you look at it from the side, you'll be able to see that it actually looks a bit like a crown, and you'll notice that that's their logo here. So this is a prospective single-arm study, meaning everybody will receive this treatment who is approved for this trial. It is a multi-center study, and it's to evaluate the safety and the effectiveness of the Anavalve system. This is for folks who are a high surgical risk. So keep in mind, all of these procedures happen through a catheter, and that catheter is about the thickness of my pen. An incision is made at the groin. Either the catheter will go up the vein or it will go up the artery, depending on which side needs to be accessed for the procedure. So right now, the way that aortic valve leakiness is treated is by open heart surgery or with medication treatment. So this will be the first valve available on the market, and this valve is the furthest along in clinical trials for treating leakiness by collapsing this valve down, putting it into a catheter about the thickness of this pen. This catheter goes up, valve gets put in place, valve stays there, catheter comes out, folks go home in 1 to 2 days. This is for patients that are high surgical risk, meaning the surgeon says, you know what, if I did open heart surgery, I don't know how great the outcome would be. I think you should go down this path instead. The aortic valve generally has 3 doors, so instead of French doors or 1 door, it's like a 3-door system. And they have to have significant leakiness. The primary endpoints are all-cause death, all stroke, life-threatening or major bleeding, AKI stage 2 or greater, major vascular complications, pacemakers, and moderate or greater aortic regurgitation. There are 30 sites and 80 subjects are enrolled every 6 months until they receive FDA approval, which we think will probably be by the end of this year or the middle of next year. Now we have Protembo. And this one here, I'm going to show you that picture there. So remember we talked about the aorta and how there's those branches that come off and go up to the brain. And we talked about how if there's tightness on a valve, that means there's calcium buildup around the door frame. Well, if there is calcium buildup around the door frame and it's really tight and it's hard to open that door, patients feel very symptomatic. They feel very short of breath. They feel fatigued. They feel lightheaded. They feel like they can't get through their day-to-day activities. So we need to fix that door. You need a new door, but we don't cut the other one out. And we've got a lot of calcium buildup. So how do we protect you? The same way we want to protect you from that clot going up those exits on the freeway if you have AFib, we want to do the same thing during your aortic valve replacement surgery or procedure. So the Protembo device is an embolic protection device that actually, during your procedure, this filter is put up and it will deflect it'll deflect across those exits on the aorta. So any bits of calcium that come off or any bits of debris that come off will not go up into the brain. It will get filtered through your system instead. This is a prospective study. It's randomized 2 to 1 to 1 in a multi-center study to study the safety and efficacy comparing the Protembo embolic protection device versus the Sentinel device, which we already use here at TMC, or no device at all. The patient population are folks who are have severe symptomatic native aortic valve stenosis, so folks who are already scheduled to have their TAVR procedure. Primary endpoints are the occurrence of major adverse events, defined as all-cause mortality, all stroke, life-threatening or disabling bleeding, major vascular complications, and acute kidney injury at 30 days. There is 40 sites, and there will be up to 500 patients. All right, we are on to the mitral valve. So here is the Atlas pivotal trial, and that is this one right here, which I like to say is probably one of our prettiest models because it is wood and it is hand painted, and I think that that's really cool for folks to share. So this is a mitral valve replacement system, the Alta valve, which you can see there at the bottom. It's kind of like a cage system that sits in the top left room of your heart, and it will replace the valve or the door that's already there. So this is a prospective single-arm study. It is multi-center, and it's to evaluate the safety and the effectiveness of the Alta valve system. This is for subjects who have moderate to severe or greater mitral regurgitation or leakiness, and or moderate to severe mitral annular calcification, meaning there are some cases where folks have a leaky valve and there's calcium buildup around, which is a twofer. It doesn't happen all the time, but it can happen. It can really complicate things, and it can really complicate how patients can be treated. So this valve can treat both of those things. The primary endpoint is composite of all-cause mortality and heart failure hospitalizations for 12 months. And the study enrollment goals are 60 institutions and 450 patients. We have the CLASP IIF trial. This is a prospective randomized 1-to-1 trial for multi-center study evaluating the safety and the effectiveness of the Pascal system with GDMT compared to a mitral clip and GDMT. And I actually don't have a Pascal with me, but I do have a mitral clip with me, so we'll have you guys look at that. But here you'll see the Pascal system, and this is a clip device. This is to repair those doors when there is a leaky mitral valve. So what it does is when those doors open and shut, and they don't shut all the way, it kind of goes like this, and we've got this backwash. What this Pascal device does and what the mitral clip device does, it will grab on to each side of that tissue and it'll bring it together. I tell folks it's kind of like, when you used to wash clothes and put them on the clothesline and then you had to put a pin on the clothesline. It's like that. It opens up and it grabs onto each side and it pulls it in. So that's how these devices work. It is for patients who have functional mitral regurgitation, and they are symptomatic heart failure patients. So they are feeling dizzy, they're feeling lightheaded, they're maybe having some swelling in their ankles and their feet, they're short of breath, they can't do their day-to-day activities. The primary endpoint is to see that the Pascal system is not inferior to the already approved mitral clip system with respect to the proportion of patients with major adverse events at 30 days. There will be 99 sites and 250 subjects. We've got the High Life EFS here. So EFS means early feasibility. It means it is earlier on in the clinical trial stage. There are a few stages to clinical trials. Once something gets to pivotal, it is at its final stage and it's waiting to get that FDA approval. This trial for High Life actually is very close to completing their early feasibility, and they already have the approval to move forward with their pivotal. So once they enroll the patients here, they'll be able to move on to that next stage there. This is a prospective single-arm multi-center study evaluating the feasibility, safety, and performance of the High Life 28mm transseptal mitral valve replacement system. This is for patients who are symptomatic and have moderate to severe or greater mitral valve regurgitation, despite being on that guideline-directed medical therapy. Primary endpoints are defined as a success as in a live patient at exit from the procedure room with all of the following, and it was a very long list, and obviously it didn't show up here. 15 sites and 50 subjects. You'll notice there at the bottom that I've got a mini math equation. That's because this is a two-part system. There is a ring, which I like to say is like a new door frame, and then there's a valve system, which is the actual new door. So this procedure gives a new door frame, and then the new door is put into that door frame. This here is a photo of actually the first High Life case that was done here in Arizona. TMC Health became the only hospital in the Southwest to offer this as an option to all their patients. This was back in January of 2023. And then this here is the first in human ever high life, large annulus valve case takes place at TMC Health, and that was not many months later in July of 2023. So this patient ended up becoming the first patient in the world to have the bigger size of this valve. Here we've got repair MR, and this one actually talks about this little mini clip here, and this is actually a real one, so you guys can come and feel it and see that that's actually how small it is. That's going into the body there. This is a prospective randomized 1-to-1 multi-center study comparing the clinical outcome of the MitraClip device versus surgical mitral valve repair in patients with moderate surgical risk. So these are those patients that the surgeon says, hey, you know what? If we did open heart surgery, I think you'd actually do pretty well. So you're not an extreme risk patient, meaning the surgeon says, whoa, no, I don't want to do this procedure, way too dangerous. The surgeon says, actually, I think it'll go pretty well. But the patient says, hey, you know, I'm a primary caretaker for my spouse, and I've got a lot of other things, and I'd prefer if I didn't have to have open heart surgery. And I love all my surgeons around here. They're wonderful and they're phenomenal surgeons, but there's not a lot of patients who want to have open heart surgery. They can have a procedure with a catheter that's about the thickness of a pen. They'll have that instead and go home in a day or two. So this device is already available on the market for those patients who are that high risk, and now we're expanding access to that. So this is for patients with severe mitral regurgitation or leakiness on that valve, and they aren't deemed suitable for surgical mitral valve repair without any calcification, so no buildup around the doorframe, or severe tricuspid regurgitation. Primary endpoints are all-cause mortality, stroke, cardiac hospitalization, AKI with renal replacement therapy, and number of subjects with moderate or less MR, so 2 or less, without mitral valve replacement or recurrent interventions in 2 years. This has 75 sites, and there are 500 patients who will be involved. Here we've got mitral 2, and this one is quite interesting because this valve is actually meant for the aortic valve replacement. So when we talked about that tightness on the aortic valve, and a valve has to get put in, and like a device like the Protembo device can be put in to deflect any of that calcium that comes off, more often than not, it is this valve that is used. And what we're looking at in this trial is using this valve for folks who have significant calcium buildup and tightness on the mitral valve instead of on the aortic valve. So that's one valve before on that left side. This is a prospective multi-cohort, multi-center study that's actually being run with Mayo Clinic. And this is to assess the safety and efficacy of the Edwards Sapien 3 or Sapien 3 Ultra, Sapien 3 Ultra Resilia valves. It's different iterations of the same valve. It's for high surgical risk participants with symptomatic severe mitral annular calcification, so lots of calcium buildup around that doorframe, with significant mitral valve dysfunction, meaning they can also have significant tightness, or they can also have significant leakiness or mixed disease. This has a primary endpoint of composite of all-cause mortality and heart failure hospitalizations through 1 year, and there will be 25 sites with 210 patients. We have the Empower study here. So that is this device here. Oh, there we go. So this one is a prospective randomized 1-to-1 blinded multi-center study to evaluate safety and efficacy of the Carillon mitral contour system in heart failure with functional mitral regurgitation. So this is the first study that we've seen where it says blinded, meaning folks will not know if they have this device put in or not. After a certain amount of time, folks will know. But in the beginning portion, we do not tell patients, and that's how the study has been designed. So we talked about how randomized was one of the most reliable ways to be able to follow data. Truly, having a blinded study is as well, because sometimes folks think that there is a bit of the effect of saying, you know, oh, I had this, so I definitely feel better, and not really realizing how someone is actually feeling. This is for symptomatic heart failure with functional mitral regurgitation or leakiness, left ventricular end diastolic diameter of greater than 57, left ventricular end systolic diameter of less than 75, and that left ventricular ejection fraction of less than or equal to 50%. This is to demonstrate the primary endpoint is to demonstrate freedom from a composite or pre-specified adverse event in the intervention group at 1 year is greater than performance goal of 90%. There will be 75 sites and there will be 300 patients. We've got the CoreCinch trial here, and this is one of our fun ones as well. So this is what the device looks like, and if we go like this, it will actually pull the device together here. And the reason for that is because once this device is implanted straight across, there are anchors, which you'll be able to see on the back, and then there are sliders on the front. This is cinched down, hence the name, and it will tighten the area that it goes into, which is the left ventricle. So this is for patients who are symptomatic heart failure patients with reduced ejection fraction despite being on guideline-directed medical therapy or optimal medical therapy. And their left ventricular end diastolic diameter is greater than 55 or more, meaning that bottom left room is starting to balloon out because it just can't push as much blood forward as it needs to. So it's starting to stretch out. And if your heart starts to stretch out kind of like a water balloon, it can only do so much. So this device actually puts anchors in across, as you can see in that first picture, and then it cinches it down and it tightens that area, kind of the way that you do with a coin purse when you cinch it down and it gets tight. And over time, what we see on the data and what we see on the imaging is that that whole room actually shrinks down together. It's not just where the device was put in. It actually shrinks down, and that ejection fraction, how much blood is being pushed forward, does increase. So patients do feel significantly better. The primary endpoints are related adverse events and quality of life through specific questionnaires and walking tests at 6 months and 12 months, and all-cause death, left ventricular assist device implants, heart transplant, and the number of heart failure hospitalizations at 12 months. One thing that's really important to know about this device and about this trial is it's the bridge to patients having to potentially need a left ventricular assist device or getting on a heart transplant list. So when we have so much stretching, there's not a lot that can be done. There are medications, but over time, patients need some sort of a support. And that support is that left ventricular assist device or it's being put on a heart transplant list. So this is the bridge to that so that we don't have to take such a big step. There are 80 sites and there will be 400 patients. That is our photo of our team having the first AccuCinch implant in the state of Arizona. TMC Health becomes the only hospital in the Southwest to offer this as an option, and this was back in 2023. Now we're on to tricuspid regurgitation. So this is a prospective randomized 2-to-1 multi-center study to compare safety and efficacy of the Pascal system with GDMT to GDMT alone in severe tricuspid regurgitation. So this is a repair option with a very similar clip, the way that the other study was, and it brings that tissue in the same way we do with a clothesline clip. This is for patients who have symptomatic, severe tricuspid regurgitation despite being on the best medical therapy that they can be. So this is on that right side of the heart. The primary endpoints are through 24 months, mortality, right ventricular assist device, heart transplant, heart failure hospitalization, and through 12 months, the quality of life improvement by different questionnaires. There are 90 sites and 870 patients. This here is the Laplace early feasibility trial. So again, in its early stage here, it is a prospective single-arm trial, multi-center study to evaluate the safety and technical feasibility of the Laplace transcatheter tricuspid valve replacement system. It's also for patients who have symptomatic severe tricuspid regurgitation despite being on the best medical therapy. Primary endpoints are freedom from device-related major adverse events through 30 days, need for reintervention for regurgitation, as well as technical, procedural, and device success. And there's 20 sites and 45 patients. And this here is a picture of our team. You can tell that I really like taking these and I really like sharing them. So this is actually the first in human Laplace case takes place at TMC Health, officially initiating this clinical trial globally. So we were the first hospital in the world to go ahead and do this procedure. And that was in February of last year. Here's a list of our upcoming trials that we have. So this is, as of right now, this list constantly has more added to it. You'll see that there's the pathology there. So aortic stenosis, tightness on the valve. We have a few options that are coming, different valves that function similarly to the way this one does, but they're designed in different ways. And we'll be going ahead and assessing those. We have another trial for aortic regurgitation. It's the same Yena valve, but now it's for patients who the surgeon says, I can do surgery on you and you will do well. So it's expanding the access for that device. We have another cerebral embolic protection trial. So one that protects those branches coming off the aorta to make sure that that calcium or debris doesn't go up to the brain during the aortic valve replacement procedure. For microregurgitation, we have that next step of that high life trial that I told you guys about. For heart failure, we have a trial called AltFlow with the Asher system, and that puts a hole actually in between the top left side and the top right side of the heart to help relieve some of the pressure. And then for tricuspid regurgitation, we have two upcoming options. One is called TriCav with the trick valve device, and it's actually a stenting system that leads into the right side of the heart. So it actually sits in the veins leading into the top right side of the heart to help offload the tricuspid valve. And we have the Vista USA study, which is the VDyne device, which is a tricuspid valve replacement system. I do like to talk about quickly our other affiliated programs. We find it very important that clinical trials are talked about all the time, not just with our patients, but with folks who are training to, go into this space, whether they're physicians or engineers. Engineers work on these devices and physicians come together with them and treat patients. So we actually have an advanced degree in engineering clinical research fellowship. We have a postdoc cardiovascular clinical research fellowship. And then we have a program called the Compassionate and Accessible Research Program. I do like to bump through these really quickly. So this is that cardiovascular clinical research fellowship for the postdoc. And then this is the advanced degree in engineering fellowship. Both of these fellows work on over 40 clinical trials, and it's not just cardiac that they work on. They also work on other ones. So they can truly understand what it takes to build a device, what it takes to test this device and to make sure that it's safe for patients and that it's effective and that we're actually bringing new options to patients that are useful for them and that are useful for the diseases and the way these diseases present. The CARE program is something that is very near and dear to my heart. I started this back in 2021 through our core values of compassion and integrity and dedication and community outreach. Our clinical research department works really closely with expert physicians, world-renowned institutions. We work with our industry partners, and we work with the FDA actually to provide otherwise unavailable therapies to our community. So there may be something out there that's not on this table here today, and it's not on my list, but you may come as one of our patients, and there may be an option out there that will work for you, but we just don't have it. We are never the type to say, you know what, go figure it out on your own. We are the type to say, let's figure out how we can get it for you and how we can find someone to do this for you here, because we don't want to send someone far away. We want you to be comfortable in your care. We want you to be able to do it at the hospital that you want to have it at. We want you to be around physicians and care teams that do care about you. So that's why we really started this CARE program, and we've been able to help so many patients through multiple procedures and through multiple expanded access programs with monkeypox and vaccines and different things like that. That wraps it up. I know I've talked to you guys for quite some time, so I'm hoping there are a couple questions or folks who want to come up and touch some of the devices. We've got Natalia Elias there and myself again. I've got the picture of our office. That is our phone number, and I have some cards as well. That's actually for our assistant, and if there's any questions that come up, I really encourage you to give a call or to send an email. We're more than happy to help you out. I tell everybody that it's really important to establish with a cardiologist, so if you haven't yet, please do so. It's never too early, and it's never too late. We always should and you can. And then in order to find our website, even though you have this wonderful handout that I just put together, you could actually, if you Google TMCZ clinical research and you click the link that looks just like that one, it'll take you directly to our website. Usually I put a link directly on here, but because the hospital is going through some updates on their website, it's not that easy for me to just put a link, so I thought I'd screenshot this.
Thank you so much, Dr. Ehsan. I do have some questions that came in, um, and there's a lot of information. So it's a lot of things that people need to think about, right? As far as what's appropriate for them. And I
Yes.
guess let's start with that. How does somebody figure out what kind of trial might be something that they should consider?
That is a wonderful question. And that's why I say it's really important to establish with a cardiologist. It is really great to have your primary care physician. Absolutely. I have so many primary care physicians who I communicate with who say, hey, my patient may have AFib and this and that. And I think that maybe this is an option. But I always love to have patients see a cardiologist, and we start there. We work very closely with Pima Heart and Vascular and with the other cardiologists here in town. So they are very aware of what trials we do have, and they probably all have our contact information. So if they say, hey, I don't know if there's an option for this, I'll get a phone call and someone will say, hey, this is how I had a patient who came in and this is what they presented with. Is there anything that you have as an option? So first and foremost, go see a cardiologist, have your primary care doctor do an assessment, say, hey, I'd like to establish some cardiac care. I may not be worried about anything, but I'd just like to see. That is step number one.
Okay, great. I had a question come in asking if the procedures that you talked about, are they able to be performed without opening the chest?
Wonderful question. So almost all the trials that we talked about are all done by not opening the chest. They're all done by an incision being made either at the groin or at the neck, a catheter about the thickness of a pen, and the device will fit into that catheter, and then using that catheter, which is essentially just a really long tube, to help get that device to where it needs to. So if it goes to the groin, it'll either come up the femoral vein or the femoral artery, or if it's to the neck, it'll go down the jugular regularly.
Okay, great. How much information do you get up front prior to maybe participating in a study? How does that look? Like, what are those initial meetings like?
Absolutely. So once a patient is referred to me, I like to have you come into my office, which is just on the south side of Grant here. And before that, I have my team schedule a phone call with me, so you don't have to come in just yet. And my team will actually email you a copy of the consent form for the study. And so I really encourage folks to read through it and to write down any questions they have. They don't need to ask me over the phone call if they don't want. I like to just give them an idea of why they were referred to me, what the study is, and set up an appointment in person. And I encourage folks to write down those questions, bring family members. I'm more than okay with folks saying, can I call my family member or my friend while we have this conversation? Yes, absolutely.
Okay, great. I want to go ahead also and put up your phone number that we were just talking about, and your email address in case someone is interested. And we can also send out your PowerPoint afterwards. So if somebody's watching and they want to get, sort of a hard copy to sort of review, I know there's a lot to watch. We're happy to do that. They can always give us a call. But I've got the phone number running here. It's 520-420-2136. Or you can email clinicalresearch@tmcaz.com. And that will get to you, Dr. Ehsan, so that you can share that, they can ask you any of those questions that they might have. I want to thank you so much for being here. I'm going to wrap up with our online audience and turn it over to you for any questions that come in person.
Thank you so much. We appreciate everyone joining in.
Thank you. Thanks again for being here today. We look forward to I hope you'll attend tomorrow. We will be talking about rebuilding heart health with cardiac rehab. So that is on Wednesday, February 12th at 2 p.m. If you are interested in attending that presentation, we still have space to attend in person. It'll be with Michael Urquhart. He is with our TMC cardiac rehab team. The phone number here, if you're interested in attending, is 520-324-1960. We'd be happy to get you registered. In addition to that, on Thursday, we have The Heart of the Matter, Navigating Cardiac Consultations and Testing. That is going to be with Dr. Greg Kashkarian with Pima Heart and Vascular, Thursday, February 13th at 3 p.m. Again, the phone number here is 520-324-1960. We hope to see you again soon. Thank you.